Welcome to another episode of Plastic Surgery Uncensored. I'm your host, Dr. Rahban, and we have a fantastic episode for you. We get probably just as many questions to our practice regarding anesthesia as we do plastic surgery, and that's understandable because anesthesia for many patients is actually the main obstacle to having surgery. As a surgeon, I don't even think twice about it because I'm in the operating room and I have experienced the wonders of anesthesia, but it has become more and more evident to me that for a lot of patients, the fear of anesthesia, and I use the word fear because it really is fear, prevents them from doing so many things they want to do. So we have had done episodes before. Dr. Houston, Michael, dear friend of mine, and our head anesthesiologist have done episodes in the past where we just sort of address the basic concerns. But what we're going to do now is we've asked for your questions regarding anesthesia, and we're going to go ahead and answer them together and try to address some of the more common concerns, basically based on what you guys have asked. So, Michael, welcome to the show as always.
Thanks.
All right, so I put these questions on this tiny little phone, so I'm going to try to see if I can read them as I'm closely approaching 50. All right, so the first question was from Juliana.Villegas, and the question is anesthesia required to treat? Her question were about festoons and malar bags, but the question should be, is anesthesia required to do eyelid surgery? So I'll answer some of that for you. It all depends. So some parts of plastic surgery can be done under local. So let's back up here and let's talk about the hierarchy of anesthesia. We have local anesthesia where you're totally awake and I numb you up.
Right.
Then we have local plus some type of IV stuff that you give. Would that be conscious sedation? Would that be the next level?
Conscious sedation, yeah.
Is twilight and conscious sedation the same thing?
For me, they're different.
What's the difference between
conscious sedation is you're still awake, you're still able to respond, but you have something on board to where you're like, ooh, this is nice.
Right. And then twilight is what?
Twilight is you're asleep like you're asleep at your own house.
Got it. So if I'm understanding this right, there's local, you're awake. We haven't altered your consciousness. Then there's this subcategory which is from conscious sedation to twilight, where you're awake. You don't have a tube breathing on your behalf, but we have the anesthesiologist giving you, or the doctor or the nurse, whoever's giving you drugs that sort of make you less alert and hence less fearful, less pain. And then you have the ultimate, which is general anesthesia, where you are completely put asleep and the anesthesiologist then manages your breathing on your behalf.
Yeah.
So back to the question is, can we do eyelid surgery under local? And it turns out that much of the face, and eyelids being one of them, you can do under local. It's a little bit difficult. And the reason is there are two parts to the anesthesia. One is the pain part, which you can knock out the pain, but the other is the comfort part, the comfortableness of it, the experience for the patient. And so I personally have chosen to do all of my surgeries under general anesthesia. And the reason is because I have a great anesthesiologist.
Thanks.
Right? I don't see there to be much advantage. So this is where I'm going to turn to you. A lot of patients have been under the impression, and I'll get to that when we have the questions more, that general anesthesia is dangerous. And as you march your way down and you go to conscious sedation or twilight, somehow it's magically less dangerous. As a plastic surgeon, I actually think the reverse personally. And I want to get your comments on that because it's not uncommon that patients like, I'll do this surgery, but only if I'm not under general anesthesia. And I'm like, what does that have to do with anything? Right. So give me your thoughts on this philosophy that general anesthesia is less or more dangerous.
For most of the patients that would come here for surgery, general anesthesia is completely safe for them. You know, they're relatively healthy, or we've gotten all of their health clearances. And so general anesthesia is going to be safe for them. We're going to be watching them carefully. We're going to have everything planned out for them. And even for those patients who were afraid ahead of time, afterwards they're like, this is great. You know,
right.
What was I worried about?
Tim, the way I understood it, and you can tell me otherwise, when you are healthy, the assumption needs to be that you're healthy. Obviously, if you're not healthy, then you throw this out the window. This is aesthetic surgery. You don't have to do any of this. You don't have a brain tumor. You don't have an aortic aneurysm. We're choosing to do this. So as you mentioned, we are very stringent on our criteria that we check to make sure you're healthy. Once we've checked healthy, then whether you're under general anesthesia where you're completely asleep and unaware and you wake up, you're like, holy shit, is it over? Versus if you are conscious sedation or twilight where you're kind of like groggy, you don't remember it. It's kind of like what we do for colonoscopies. My understanding was that for an anesthesiologist, it's more difficult because you have to keep the patient in a very small bandwidth. If they are too awake, they move and they
uncomfortable,
and they're uncomfortable, and they make the surgery for me miserable. And if they're too deep, they're not going to breathe because there's no tube in their throat.
Right.
So whereas with general anesthetic, I'm not saying that it's not difficult or it's not relevant. You have a tube protecting the breathing. So even if you're overly done or underdone, the machine is breathing for you. With conscious sedation, if the anesthesiologist isn't paying attention to you and you're not monitored and you dip too far in we gave them too much and they stop breathing, I was under the impression that that's more concerning than general anesthesia.
That aspect of it can be true. Yeah, it can be true at times. Yeah, I do conscious sedation all the time in other settings, but yes, it can be more fine tuning.
Do you think that for an average anesthesiologist, right, is it easier to do general anesthesia? In other words, the concern is the patients who are out there are going to any facility between here and Timbuktu. They don't know the level of anesthesia provider. It could be an anesthesiologist, it could be a CRNA, for God knows it could be just a nurse pushing propofol. And so the question I have is, I almost feel like general anesthesia is a safer type of anesthesia for undertrained people, and conscious sedation requires more skill because you have to fly in a certain zone. Is that not true, or is that not accurate?
I would agree with that for the most part. Yeah.
Right? Don't you think if you're not the best anesthesiologist, it's easier for you to do general anesthesia?
Probably a little bit safer under most circumstances.
Right?
Yeah.
So anyway, for me,
or more controlled.
More controlled. So you have more safety net.
Yeah.
So this generally answers the question regarding conscious sedation. So the question was, can you do eyelids under local? Local means no additional medication. The answer is you can do some parts of it. Yes, the upper eyelid you could, for example. The lower eyelids you won't be able to do because it's just too much pressure on the eyelid. But by and large, there's people doing mini facelifts under local. So the answer is you can do it. I don't like to do it because I feel that I don't have control. If you were to have an issue like bleeding, now you're awake, you're bleeding, there's no anesthesiologist here. So I prefer doing all of my cases under general anesthesia with a kick-ass anesthesiologist by my side so that she's taking care of the anesthesia while I can focus on you and you are asleep and safe.
Tahiti.
Tahiti, as we would say. Okay, so that answers that question, probably, and 20 other questions. So, okay, you'll like this question. Tamia5 asks, I'm always nauseated after anesthesia for 48 hours. Any tips? And this couldn't be more relevant because
to Tamia5 and everybody else out there, I'm really prone to nausea myself, big time. So
she's highly sensitive.
Yes.
All anesthesiologists should care about nausea, but naturally, if it's something that happens to you, you're more heightened awareness. So let's go through all the things you do from the basic, and you just keep working your way down to help with nausea. Now, I'm going to mention this. If you're prone to nausea, you will be nauseous. I think that irrespective of all 77 maneuvers, if you're truly, the goal is to get it so that it's manageable and not overwhelming. But let's hear what are our steps for nausea.
Yeah, so probably the first step is going to be reassurance.
Got it.
Know that I understand what you're going through, that either you've had it before or you know someone who's had it or you just read about it and you don't want that because nausea sucks. So lots of fluids. I'll give you lots of fluids. You can't eat or drink anything before surgery, so you're counting on us to give it back to you, and I'll do that. I have about 6 different medications that I give. including additional propofol towards the end of the surgery. And anything else? Do you think they want to know the specific medication? Zofran.
So first thing we do is, as you had said, we extra hydrate you, because as it is when you come in, you're dehydrated. You haven't had anything to drink or eat since midnight or even earlier. And when you're dehydrated, in general, you're prone to nausea.
Yes.
So we slam you with fluid so that you are super tanked up and very full of water, because that helps. Secondly, we give you different drugs. So
that all work different ways.
There are different approaches or different avenues to nausea.
This is really important. There's also specific drugs that I will not give you because they are just known to cause nausea.
Perfect.
So there's no point in giving them to you.
Right. So first we tank you with fluids. Here are the drugs to avoid, and you tell your anesthesiologist, hey, I'm prone to nausea. Make sure you don't give me
Demerol.
Demerol is one of them.
That's probably the
main one, right?
Yeah. I'm not going to give you extra Dilaudid. I'll give you other pain medications.
So pain medications are
Tylenol.
super nausea-provoking. You need them because you can't do the surgery without them, but there are some that are less and some that are more. Would you say fentanyl is less nausea-provoking?
Yes.
Right. So you want to, in general, stay away from Demerol. It's like the devil when it comes to nausea.
If you're really prone, correct.
Now, on the flip side, here are the medications we give you, and we give you various medications at all directions to try to knock down your nausea from different, if you will, entry points. One of them is Zofran.
What
else?
Reglan. Decadron.
Decadron is a steroid. We give you a steroid to knock down your nausea. What else?
Pepsid to reduce the stomach acid.
It reduces your acid production, which can, again, anesthesia causes slowing of your gut. And so you then often have a buildup of acid, and so we want to knock down the acid. What else?
The scopolamine patch.
We give you a scopolamine patch, which is kind of like Dramamine. It's kind of like Dramamine. It's sort of
a longer.
It's a when for motion sickness, we put a patch on you, which then will carry you through after surgery.
Correct. What else? And then this is not directly anti-nausea, but lidocaine. So now I've started giving a small additional dose of IV lidocaine to help with the pain control without having to use more opioids.
Right. So the answer is, I'm going to try to reduce the amount of narcotic I give you so that you don't get nauseous. The last one I remember is you had mentioned it gives some propofol, which is actually the drug Michael Jackson drug, that puts you to sleep. But if you give a small amount of it, it helps curtail your nausea. So as you can see, there are lots of things you can do for nausea, and your anesthesiologist has to give about your nausea and saying, hey, we gave you a little Zofran and, you're going to get nauseous. Because aside from nausea being a miserable experience, it can ruin your result. If you are post-op from a facelift and you're retching, you're going to pop a leak. You're going to get a bleed.
Tummy tuck.
Tummy tuck, same thing. Breast dog. Nausea is really important. Let's keep going here. All right. Manhattan Beach Fitness. Why is everyone talking about twilight anesthesia being safer? Is that true? Hold on. Mother of Wolves X. Why do some doctors use twilight and others use general anesthesia with oxygen? Emmy_mock. Is there ever a case you'd operate on someone with something other than general anesthesia? So that's why I kind of went on a little bit of a tangent, because I knew these questions were coming. So again, let's just describe anesthesia in general. Local, just some numbing medicine, Novocaine for your teeth, etc. Then there's a middle bracket where you're not fully asleep and not awake, and you're in this little buffer zone. It can be conscious sedation or twilight, kind of like when you go get a colonoscopy.
Correct.
And then there's general anesthesia where your anesthesiologist is breathing on your behalf because they've sedated you to a point where you're deep enough where you're not moving and you're not doing anything and theoretically not feeling anything, but certainly you can't breathe. I, in general, and this is a matter of your doctor and your anesthesiologist preferences, don't like the other methods because I do not believe they are safer for all the reasons mentioned. I think the patient experience is 1,000 times better when you're knocked out. What? It's 4 hours? How did that happen?
Right.
You're asleep and it's over. And God forbid there's an emergency. I have much better control and I can do the things I need to do. So I hope that answers all 18 of your questions. All right, let's take a quick break.
Yeah, and definitely, that's true in regards to the cases that we do here.
Yeah, I mean,
if somebody's going for like a bunion, knock yourself out. Do what you want to do.
So that's a great point that you make. We're addressing the needs of different anesthesia based on the procedure being done. There are procedures that you absolutely have to do under general anesthesia. There are procedures that you should absolutely do under local.
Right.
And then there are procedures that you could pick. When a choice is available, I tend to lean towards general anesthesia. But each doctor needs to have a comfort zone with the procedure they do. If a doctor's been doing something and they've done 1,000 of them under conscious sedation, then they know what they're doing. Knock yourself out. Just speaking of which, Joan Rivers.
Oh yeah.
Was it her issue that they were doing conscious sedation in an outpatient environment and they lost the airway? And
then I don't know the exact details, full disclosure. But I thought I heard that there was not an anesthesiologist.
There wasn't. There. No. So my understanding, don't quote me on this, I will absolutely deny I ever said this, even though it's on camera, that Joan Rivers went to, it was a very prominent ENT clinic. She had some procedure to her vocal cords or her lungs or her bronchial, I don't know what it was. And during the procedure, which was conscious sedation, if my understanding is correct, the airway became lost. She bled or she swelled up or I don't know. And there was not someone there to intubate the patient and control the airway. And I believe that's how she died. Could be way off field, but it is that story-ish that makes me uncomfortable. So I don't even want to go there. All right, let's take a quick break and then we'll come back to the second half of plastic surgery with Michael Houston extraordinaire. All right, welcome back to the second half of Plastic Surgery Uncensored. We are doing a deep dive into your anesthetic questions. And so let's see what we got here. We have Pilly Mom. Is it important to use a board-certified anesthesiologist just like you recommend for the plastic surgeons? Should we ask the plastic surgeon about the credentials of the anesthesiologist, or would that be offensive to surgeon? Fantastic question. God bless you. Pilly Mom. So absolutely, you absolutely need to ask the plastic surgeon, who the hell are you working with? Who's your anesthesiologist? Is your surgery center accredited? Everything. You cannot no longer can you go into any kind of procedure blind anymore. Those days of paternalistic medicine where you're like, well, my doctor said so, that's long gone. It's not offensive, it's just being informed. And I don't want to suggest that any version other than a board-certified anesthesiologist is unacceptable. It's just board-certified anesthesiologist is the lion in the jungle. Then it's not
board qualified.
There's board-certified, board-qualified, not board-certified. In my humble opinion, then there's CRNA. And for those CRNAs who are going to listen to this, they're going to get all bent out of shape. But I didn't say you can't do anesthesia with a CRNA. It's absolutely acceptable. As a matter of fact, they run many medical centers. I've done tons of medical missions in Guatemala with CRNAs. They're amazing. So for all you CRNAs, don't get bent out of shape. However, training-wise and experience-wise, there is a distinction between a nurse practitioner, a nurse anesthetist, and a board-certified anesthesiologist. Absolutely there is. Nevertheless, you need, as a patient, to ask these questions. And depending on what they tell you, you then can make your decision. Right? The key is just to know who is there and what is their training. Why? Because there are shady people out there. And if your doctor is offended, there's your answer. Right there is the answer. If you're offended that your spouse questions your faithfulness because there's something of concern and you get all bent out of shape, I think you did something illegal. That's just the way I see it. If you've done nothing wrong, I'm at the airport, I'm Middle Eastern, you want to pat me down, put me in an x-ray room, knock yourself out. Oh my God, why? Yes, we have blown up planes. So come check me out. You know what I mean?
And it's just good to know if they know anything about the people that they're working with.
Last but not least, very important. I only work with the anesthesiologist that I've known for 17 years. The end. I don't use random anesthesiologists. That being said, the overwhelming majority of surgery is done in an outpatient and surgery and hospital setting. The overwhelming majority of all surgeries done are done with an anesthesiologist who happens to be on the schedule that day. The overwhelming majority are not done because the surgeon has requested that particular anesthesiologist, or that anesthesiologist works exclusively with that surgeon. That doesn't mean that it's not okay. It means you go to the hospital and whoever's on that day, that's their day, or that's their room, or that's who's there. But I think, in my opinion, teams that work together, you're never going to have a heart transplant where some random anesthesiologist shows up. You're never going to have any, a stroke
burn graft,
right? Teams are designed because the anesthesiologist, the surgeon, the tech, and the nurse, and a few other people are all work together on a regular basis. So I think it's important not only to know who the anesthesiologist is. No, I think it's not only important to know what their training is. I think it's important to know how often you work with them, because I can tell you that,
or at least similar type of cases.
Yes,
at a minimum.
I can tell you that when Michael's on vacation, we're miserable. Right? Because we have no choice. We have to bring in people that we've worked with, but it throws the whole thing out of whack. So don't go on vacation. All right. Let's see here. La Rumbera. I'm presently taking Ozempic to lose weight, and I'm considering to do a tummy tuck in the near future. Can my weight loss treatment have an adverse effect with anesthesia? If so, how long do I need? So this is a great question. Ozempic is ubiquitous. It's everywhere. It's taken over. It's like Botox, Ozempic. I mean, it's...
And all the other ones as well.
Yeah, Ozempic, Wegovy, and Mounjaro.
Yes.
And I'm sure tomorrow there'll be 7 more. So we don't know. Mm-hmm. We don't know exactly the anesthetic effects yet, or do we?
They know a little bit,
so
but definitely, to be honest, the exact details escape me. I do know this though. Hold off for 2 weeks.
Right. And what I was going to say to you is,
it may make some things more.
Is it a gut-related thing? It slows down your gut emptying?
But it goes into all of your metabolism and everything.
So what I have understood is...
It slows some things down and it speeds
my understanding, and again, I could be wrong, but I'll tell you the bottom line of it. I think what it does is somehow causes paresis, or slowing down of your gut system.
Yes.
And as a result, you're at a higher risk of aspirating, which means that you choke on your own vomit. That's not relevant. What's relevant is that we don't know enough. And as a result... Our general philosophy when it comes to drugs that you're taking that are not life necessary. What's a life necessary? Your insulin is life necessary. Your hypertensive medication for your blood pressures. Things that if you don't take, you're going to not be healthy. We generally have you stop all those things, including supplements, 2 weeks prior. The reason being is that's an adequate amount of time for that thing to go through your system and not have adverse effects. I assure you that if these drugs are in the market in 3, 5, 9 years, we'll know much more specific details of when, where, how, what. But for the time being, our suggestion has historically been 2 weeks, hold off, 1 week after hold off, and then go back and do whatever it is that you were doing.
Right. And of course, if you're a particular person, your endocrinologist sends us a note. That'll be different.
I mean, if somebody comes with a clearance and we have data and science, but generally speaking, my philosophy is, do you need it to survive?
Right.
No, not really. Then stop it. Because I don't want to deal with it. Nothing's going to happen to you if you don't take your clover loaf, powder from the, whatever nonsense you're taking, St. John's root, whatever. All right. PDX5. Can you still go on general anesthesia if you have a sleep disorder like sleep apnea? Great question. Why? We had a patient who recently sent us this question. Actually, her doctor canceled the surgery because she has sleep apnea, which we think is nonsense. Sleep apnea is a condition in which when you are sleeping for a host of reasons, you go apneic. Apneic means you stop breathing. What does that mean? You're sleeping and you stop breathing. But that's irrelevant when you're having general anesthesia. We're breathing for you. As a matter of fact, it's the safest response for sleep apnea. So sleep apnea doesn't have anything to do with general anesthesia. Now, some individuals, as a result of chronic, really bad sleep apnea, get hypertension. They have pulmonary hypertension. They have all these other conditions.
And we definitely will watch those patients a little bit more carefully than we normally do throughout and also post-op.
Sure.
But it's not a reason to not have surgery once you've, gotten your pulmonary clamp.
Right. So what happens is you have a condition. In this instance, it's sleep apnea. In this condition, it's diabetes. In this condition, it's hypertension. We require your doctor who manages that condition to say that your condition not went away, but is managed. It's under control.
Correct.
In which case, when you're under general anesthesia, you're behaving the same you were before you were under anesthesia. You are stable. So sleep apnea, stable sleep apnea, well-controlled sleep apnea, in our estimation, is absolutely not a contraindication to having surgery.
Right.
We believe you will do just fine, assuming your doctor is good, your post-op care and recovery is good. As a matter of fact, my producer Maria, who had recently had a breast explantation, reduction, lift,
Right.
etc., she had sleep apnea, was on a CPAP machine.
It's not uncommon.
And was actually very concerned naturally, and she did a breeze. As a matter of
Right.
fact, her sleep apnea is better, but that's neither here nor there. Okay. Dills. What are the possible side effects of general anesthesia, and what are the risks of dying from general anesthesia? So those are two separate questions. Let's address the one that's easy. The risk of dying from general anesthesia, we don't know the exact statistic, but it's 0.01 million %. In other words, it's super rare. You are more likely to get run over by a drunk driver statistically than die under general anesthesia, caveat, with a legit anesthesia provider in a legit environment where you are healthy individual. So let me rephrase that. You are healthy. You didn't walk into general anesthesia with a high blood pressure of 192.
Or even if you're not 100% healthy, but everything that can be disclosed was disclosed.
Right.
You or someone in your family said, hey, they have this, and this. I'll alter what I'm going to do. It will keep you safe. Your risk is a little bit higher, but it's still not, you're going to...
Well noted. One of the amazing parts that you guys don't understand about anesthesia is they go into manual mode. So let me explain this to you. When you get a DSLR camera, 99.9% of people put it on auto and they shoot photos. And the camera is deciding your aperture, your shutter speed, all these things, because we don't know what we're doing. When you get anesthesia, they put it on manual. The anesthesiologist regulates your blood pressure, regulates your heart, regulates your oxygenations, opens up your lungs, puts in stuff that dilates things. They literally micromanage everything about you. So if you end up coming in, you got into a car accident, they don't have time to get you cleared. They take care of you and you would do fine. So you dying from general anesthesia is one of those urban legends. Those are fears that people have, just like people are afraid of dogs, people are afraid of flying. They're not rooted in reality.
Bugs.
There you have it, insects. So you will be fine. Absolutely fine. Obviously, don't go to some strip mall in the middle of like Miami, whatever. But generally speaking, not a concern. Now, the other question, which was more apropos, what are the side effects of general anesthesia?
So two of the main side effects, if left unchecked, are like shivering and nausea. So those are two of the main side effects.
Short term, right?
Short term.
So what it is so let's just talk about reactions and side effects.
Oh, and sleepiness. Once again, short term. But, after the fact, you're like, I feel groggy. How do you feel? I feel okay. I'm sleepy. I'm tired.
So I'd like to qualify that. That's a distinction between reaction and side effect.
Right.
A reaction is I had general anesthesia, and for 12 to 48 hours, I am nauseous. That's not a side effect. That's a reaction to the medications. I am groggy. That's a reaction to the medications. And immediately in recovery, which you won't ever remember, you might have a little shivering. That's something that you won't even know. On the flip side, I can tell you two things that I know of that is associated with anesthesia. Now, these are actual side effects. Done, I had my general anesthesia, and here are some things. One, your menstruation may be altered.
Correct.
So there are many, many women who undergo general anesthesia for a number of reasons, and then they find out that they missed their menstrual cycle, or it came early and then it didn't come for 4 months. It throws off your menstruation.
And I would agree, and that's from the anesthesia and the surgery together. Your body went through the stress of surgery.
So that is
and
one.
Anesthesia.
The other is short-term hair loss. It is not uncommon. Again, this tends to be more common in women than in men, and I think it's hormone-driven. And it's not the actual anesthetic, but I think it's just the shock of the system that you lose hair for a period of time. And that hair will always come back because it's not a long-term side effect. So in general anesthesia, modern day general anesthesia is phenomenal. It is really a truly remarkable component of medicine that without which we would literally be doing no robotic surgery, no spine discs, no intracranial electrode placement, nothing. It is the gateway to all of the incredible face transplant, right? All these things occur through general anesthesia. All right. Bibblerd. Is it possible to wake up in the middle of surgery? I love these questions. You guys ask great questions because on our last episode, which was several years ago, we addressed these individual things just because we knew people would be concerned, but I like that you guys are asking it. So again, another one of these, the reason why this show is so relevant and why we do it, we try to do it often, is because anesthesia is that thing people are scared of. And it's almost 90% of it is urban legend or I heard, or my friend told me. So
that her cousin,
right? That her cousin's gardener knew a guy in Guatemala. So they're. I'm going to break this into two parts. One is, can you wake up during general anesthesia? And the other I'm going to add is be awake and paralyzed. Those are the two things that people are afraid of. So let's address that.
So I have never personally had a patient who has had awareness during the anesthesia, but I have had patients who've told us or told someone else that, like you said, either they or their mom or their cousin or a friend was awake during anesthesia, at some point. And they're not trying to get anything out of it. I don't know whether it was true or not. I don't know if they're remembering something from a different period
or
something
mechanism?
Like that.
So take me through the mechanism of how a person can be awake.
Could be awake.
So as far as awake is very simple.
It's not enough anesthesia.
You're not deep enough.
Right.
The way you're awake, next thing you know, you're under general anesthesia. There's levels of depression. So awake, totally awake, stop breathing, you died. Right? There's this thing here. And as the doctor gives you more anesthetic, gases, injections, medications, narcotics, your consciousness, your physiology is shutting down. Your heart is slowing down. Your mental capacity is slowing down. And your lungs stop breathing. The whole purpose of general anesthesia is to get you low. Let's say this is the floor. You're up here. I mean, you're miles away from being deceased. But they try and keep you close to the surface so that you're safe. Now, it's possible that during anesthesia, your anesthesiologist runs you a little light. Remember, their objective is to keep you not super low, but low enough where they can do the surgery safely and bring you back out.
And it can also happen to where the anesthesia provider is administering the correct amount and something is blocked to where it wasn't getting through or something like that.
Right, so that's a very good comment. Let's say remember, how do we get all the drugs in you? Aside from breathing them, some of them are intravenous. Let's say your elbow is bent and they're giving you the drugs, and for a very short period of time, but this idea that you're awake, you don't go from general anesthesia and then you're like, oh my God, you should see people in recovery. It takes 30 minutes to come to, even after they shut everything off. So what is possible is that you get a little light. And during surgery, patients will start moving or bucking. They have no recollection of it. And then the anesthesiologist who's there, they're not down the street, who's there goes, oh, okay, this patient is metabolizing more than I had anticipated. They work out, they have a gene that eats through it more, and they just turn up the dose. But it really is very, very, very unlikely that you'll just wake up from anesthesia. Now, talk to me about this awake but paralyzed component, because this is like the biggest fear of all patients in the world. And every so often you watch one of these late night shows and a guy's like, I was awake and they were hammering my femur and I couldn't tell them anything. And everyone's like, never having anesthesia again.
I'm glad that you said hammering their femur, because I have heard of that, and it might be, some of those circumstances might be someone who's having, say, a C-section. So they got a spinal or an epidural. And so they can't feel it, thank goodness. But up here, they were given something, but now it kind of wore off and they're a little bit awake. Or a knee replacement or a hip replacement or a foot surgery, to where they get, temporarily, intentionally paralyzed and numbed on their lower extremity, and then a little medication up here to be sedated, and then it may have worn off, something like that.
So let's chat about that, because I think that is exactly what happens. So we talked about local conscious sedation, general anesthesia. We left out spinals, right? Epidurals and spinals. And what that is...
And nerve blocks.
And nerve blocks, which that means is that your anesthesiologist takes local, the local you put here around your eye or your lip or whatever, and takes local and sticks it in the spinal canal and numbs everything below that level down. So a very common one is an epidural for C-section. It's like the standard way of doing things. They don't want to knock you out. You are awake, but you feel nothing from the, rib cage down. Okay? But it is very common, not in a C-section, but for other cases like orthopedics where they are traumatic, right? That they give you drugs that sedate you, so you're conscious sedation on the top of your body, and you are nerve blocked or spinal epidural on the lower part of your body. And what happens is that you kind of lighten up, and then you wake up and you're like, oh my God, I'm paralyzed. Yeah, you're paralyzed. That was the procedure, and I'm awake. So that all being said, the total number of such cases is minor, if at all ever. So I certainly wouldn't not go get my whatever fixed because I'm afraid of it. I think that leaves us with the last question.
Okay.
And look at that. Somebody put this thing together and it's brilliant. So it says, Mama office. No, Mama 5. Mama 5, corrected. Can tummy tucks be performed with an epidural and sedation versus going under general anesthesia? So that was like, it couldn't have been a better log. So can you do an epidural-based tummy tuck?
Let's say we were in a different setting or something like that. Could it be done? I would say it could be done.
You can't paralyze the muscle.
Well, are they having the DR repair?
Well, I mean, just elevating the muscle flap. Just elevating the flap goes ding, zzz, zzz, right?
Oh.
Right?
I see. So there you have it. What was the name again?
Yeah, Mama 5.
Mama 5.
So let me explain to you yes and no.
Okay.
Yes, your anesthesiologist can put... Can you explain to me the difference between a spinal and an epidural real quick?
Spinal goes in, it goes into the
spinal
CSF.
canal, and the epidural is on the outside of it.
The outside, so one is past the...
Dura?
Well, yes, past the dura, and one is outside of it.
Okay, and what difference does that make in terms of the anesthetic? Was one shorter, one longer? Does one go somewhere?
One is you're giving us the spinal. You're giving a much smaller dose, and it's going to come on, but it's going to wear off. Usually, depending on which exactly local anesthetic you use, more quickly. One is designed usually to where you can place a catheter for the epidural, and it's much larger amounts and dosing. And it can potentially last longer. So you use the spinal for a short case and you use an epidural for a longer case. Is that how you choose? That's one way to think about it. Yeah.
So and let's just say it's an epidural for the tummy tuck. If we wouldn't do it with a spinal. It would wear off. It's a 3-hour case. So we put an epidural in. Yes, your anesthesiologist can make it so that you are awake and you feel nothing from your rib cage down. Right? Because your concern is anything lower than your diaphragm, right? That's the area, right? So you can knock this part out, right? Because you do a baby delivery and they don't feel anything in their abdomen. So yes, the problem you're going to run into is that in order to do a tummy tuck, my tummy tucks, I need the muscles paralyzed. because when I'm opening the abdomen with my cautery, the muscles are twitching, and I need Dr. Houston to give the muscle relaxants so that there's no twitching of the muscle. The minute she gives you muscle relaxants, you stop breathing because she's knocking out all the muscles, and that includes your breathing muscles.
Yeah.
I can't open without muscle paralysis, and I can't repair your separated muscles, your diastasis, which is 90% of tummy tucks.
Right.
So yes, you can have it. I know there's doctors could do breast dogs, but it's the same issue with it because I need paralysis of the muscles. So I don't think it's a very effective way. And the only reason people are asking is because they're afraid of general anesthesia.
Right.
Right? They're afraid of like, oh, how do I avoid this horrible thing? Well, that's it, ladies and gentlemen. You guys have done an excellent job. We thought we'd try this approach to anesthesia dialogue as opposed to our last approach, which was just sort of a boom, boom, boom list. I kind of liked it because you guys did a good job and asked some good questions. All right. Any parting advice for those people listening at home who are just dying to go get some surgery done and they're freaking out about anesthesia?
Yeah, just continue to do your homework from reliable sources, from reputable sources, not just like some random source.
So TikTok, is that reliable or not reliable?
Right. So, and then, yeah, you can look at the American Society of Anesthesiology websites or something like that and get reliable information.
Yeah, I think the reality is that the same amount of emphasis and energy you place at selecting your surgeon, that sort of, oh my God, this guy's going to cut me open or this woman is going to, you should be really inquiring about the person putting you to sleep because they are the co-captain of this experience. And all too often, patients go in and they just sign over to the doctor and then they just assume that the rest of the team is going to be great. And it just isn't the case. And the question is, why not? And the answer is money. Because the other members of the team are additional cost. And so if the doctor wants to be greedy and it is in their best interest to keep as much money as possible, they will hire perhaps maybe less effective, less qualified, more affordable.
Or like you said, to where it might be a very, a perfectly acceptable anesthesia provider, but they just never even worked with that person before at that place.
Right.
So they don't know where everything is, or it's a little uncomfortable, or the dynamic is off.
Yeah, I really think the fact that we work together 3 times a week, the dynamics and the smoothness, it's so well orchestrated that when we're in the operating room, God forbid, something were to go wrong, the speed in which we can address it is going to be far greater than if it's your first time in a new environment. You've never been at this facility. You and the doctor have never interacted before. I do think that creates a huge issue. Nevertheless, the most important thing is anesthesia is safe. That is the key thing for you to take home.
Yep.
All right, guys. Well, thank you so much for coming.
Thanks.
I very much appreciate it. I'm sure the patients will love this episode. As always, 2 things I'd like to impart before we get off. 1, if you like the show, go write something nice. People like to hear nice things. If you have nothing nice to say, don't write anything. And then the second thing is if you love someone and you think that they might want to do aesthetic surgery or they're planning on having surgery, then as always, share this show with them because you'll never know till it's too late that they had something done and you're like, God, if I had only known. So, as always, I'm your host, Dr. Rahban, signing off. Until next week on Plastic Surgery Uncensored.